Nutritional correction, because many of the patients will be nutritionally debilitated. Rehabilitation physically, both pre and post-op as well, and optimization of the underlying comorbidities. There are many guidelines, medical societies, and recently surgical society guidelines have also been issued, including AATS guidelines and ESCTS expert statement as well. And a class of recommendations have also been issued for particular procedures and surgical methods as well. Coming to chest tube drainage, indications include presence of pus on aspirations or presence of microorganisms, low pleural fluid pH. In a loculated collection, ultrasound guided ICD insertion can be considered, which will be much more safer as well. Fibrinolysis, many trials have already been conducted, but not much of improvement or outcomes have been notified. Only to be considered in patients who are unfit for surgery, and the two with a dual agent including tissue plasminogen activator and a DNS combination. Role of surgery, a surgical opinion should be considered in all cases who fail to respond to medical management, including antibiotics and drainage. Approach, recently minimal invasive approach has also been included in management of empyema patients, and VATS is being considered as a first line approach in at least in stage 2 empyemas, which carries a class 2A recommendation, and if patient can tolerate a single lung anesthesia. And many studies have reported at least equivalent outcomes even in mixed population of both stage 2 and stage 3 as well, along with advantages of minimal invasive surgery. However, limitations include not all patients are exactly stage 2 empyemas. Coagulopathy might be a relative contraindication for minimal invasive approach in empyemas, and surgeons team experience in minimal invasive surgery, and a lower threshold for conversion in difficulty cases. Chronic empyema, where there will be cortex formation and trapping of the underlying lung, and just the drainage procedures might not be effective in this stage. So you need to add probably decortication is a standard method where patients are fit to tolerate a major thoracic surgery. However, the necessary assessment include preoperative assessment of the underlying lung, whether it will expand and fill up the space or not. Conditions which needs to be ruled out include bronchiectasis, fibrosis and calcifications, and previous parenchymal resections like post-surgical cases, and if there is a previous pneumonectomy. And presence of any fistulas also needs to be ruled out by probably with CT assessment and bronchoscopic assessment. Decortication is a standard procedure for stage 3 empyema. Preferably, many cases are done by open approach. However, the principles needs to be maintained, which include evacuation of the collection and mobilization of adhesions, removal of visceral pleural cortex, parietal pleurectomy, release of diaphragmatic and mediastinal adhesions, and fisural release if possible. The steps have been described very well in our good old textbook of Shields itself, where the mobilization of parietal pleal is done between thick parietal pleura and the endothoracic fascia, and the visceral pleura mobilization between the thick and visceral peel and the visceral pleura. Even VATS has also been described in stage 3 empyemas, however, requires a significant learning curve, and success correlates with increasing experience and skills as well. Whatever the method, either the VATS or the open method, the intended results should be the same, where to get the collection cleared as much as possible and to get the lung expanded completely, and more important, to restore the breathing mechanics. There are some contraindications which are also mentioned in textbooks as well, in a case of bronchial obstruction, pulmonary destruction, uncontrolled sepsis, contralateral disease, and chronic debilitation. Even recently uniportal and awake VATS has also been described in at least in stage 2 empyemas. And recently many physicians are using medical thoracoscopy for management of empyema, usually in stage 2 empyemas. However, needs more clarification to segregate patients between medical and surgical indications, and more importantly contraindications. And especially with recent advent of uniportal and awake VATS, the role of medical thoracoscopy can be questioned, and it needs further addressing. Lung resection is difficult to predict in any empyema case, better to avoid as much as possible. However, if forced to do as less resection as possible, and important to avoid bronchial stumps in an empyema phase which are prone for fistula formation, and probably can consider muzzle flaps to buttress the closure. Role of open window thoracostomy is probably reasonable in chronic empyema patients who are unfit for decortications and helps in control of infection either definitely or as a bridge to a definitive surgery. Representative picture showing an immediate and follow-up picture of open window thoracostomy. A role of empyema tube, occasionally we also use in few of our own patients, particularly where there is a small infected space or there is a small empyema space where you can resect a small segment of rib and put a white tube for drainage, and can be done even in sick patients, even under local anesthesia as well. Helps in at least control of sepsis in this group of patients. Recently, VAC has also been described in management of empyema, where there are sick, which will accelerate the recovery of the patients, otherwise in any sick patients, where you will end up with an open window thoracostomy for a long time. Empyema with BPF, closure of BPFs can be attempted either with a combination of primary closure with buttressing with an vascularized flap, or transposition of omentum may be preferred in a bigger fistulas. Role of myoplasty can be considered in patients where underlying lung is not able to expand and fill up the space. Different muscles have been as described earlier as well, pectoralis major, latissimus dorsi, including tram muscles as well. Thoracoplasty probably can be considered as one of the last resort procedures where all other procedures have failed, which includes multiple rib resections to allow the collapse of the chest wall to bring the opposition of the visceral and the parietal pleura. Representative picture showing an intraoperative and follow-up X-ray. Coming to conclusions, I would say empyema thoracis is a very heterogeneous entity. Both disease stage and patient factors has to be considered in management. It's not like that it's a single procedure for all cases. There is lot of learning. Even till today we also continue to learn for management of empyema, and I would say this is one disease which has taught so much in thoracic surgery. Whether our VATs are open, the endpoint should remain the same as well. Thank you.
Thank you, Dr. Vijay. Comprehensive talk on empyema. I think question after this last talk. Yeah. And the next last talk is by Dr. Lochab. He is the director of Pandit B.D. Sharma Postgraduate Institute of Medical Sciences, Rohtak. And he will be talking on approach to patients with mediastinitis.
Good evening, everybody, chairpersons. I am thankful to Dr. Diwan, Dr. Pallavi for inviting me for this talk. Although a lot of has been discussed about infections in previous two lectures, I will be talking primarily to mediastinitis. And this is sternal wound infection related to median stenotomy post-cardiac surgery. Median stenotomy was described by Milton in 1897, and it is most common access to the heart and mediastinum, and all types of cardiac surgery, almost all are being performed through median stenotomy. The incidence of sternal dehiscence with or without infection range from 0.5 to 5%, and it is a serious complication, and we should not take it lightly, and in fact a difficult challenge. The incidence of mediastinum has not much declined over the last decades. Surgery is more frequently performed in patients with a high risk of patients despite improvement in preventive measures. Sternal wound infection leads to prolonged hospital stay and is responsible for in-hospital mortality rate from 8 to 35%. The classification of mediastinitis is by Oakley and Wright, mediastinal dehiscence, that is sternal dehiscence in the absence of infection. And second is mediastinal wound infection, that we generally divide into superficial, confined to subcutaneous tissue, and deep sternal wound infection due to osteomyelitis. CDC guidelines define it for this thing: diagnosis of mediastinitis, deep sternal wound infection, positive culture of the mediastinal tissue or fluid, evidence of mediastinitis seen during operation, or one of the following: chest pain, sternal instability, fever more than 38 degrees with either purulent discharge or positive culture. Staph aureus is most common, 42%, followed by negative Staphylococcus, 24%. Other organism, gram-negative fungus are less common. And in fact, this coagulated negative staphylococci is from local pocket, and that is usually due to obesity and COPD. Staph aureus requires this thing, it leads to aggressive systemic signs, bacteremia, sepsis. It usually happens due to perioperative contamination and nasopharyngeal colonization. Gram-negative bacteria are not so common. The risk factors, as for other infections, also are here: old age, male gender, obesity, osteoporosis, COPD, diabetes, intake of corticosteroid, heart failure, poor dental hygiene, prolonged hospital stay, IEBP. Perioperatively, untimely antibiotic prophylaxis, hyperglycemia, when we take both IMAs for CABG, redo surgery, and use of excessive bone wax and prolonged surgery. Post-operatively, when there is re-exploration, multiple transfusions, prolonged ICU stay, or prolonged ventilation, these are the risk factors. The diagnosis is usually, we can make by either clinically, by sternal instability, tenderness, erythema, wound adhesions, fluid or purulent discharge. Investigations, of course, there may be leukocytosis, and we can draw the fluid, the sternal puncture, and get the culture sensitivity done, and blood culture. Chest X-ray has not got much role here, and CT scan can tell us extent, depth, and localization of infection, and CT-guided fluid aspiration culture can be done. Another tests are nuclear imaging, leukocyte labeling with technetium-99, echocardiography, transthoracic, transesophageal to rule out endocarditis in valvular patients. Prevention, we should always stress prevention to prevent this lethal complication, and in fact, there are different guidelines, and we should follow those guidelines to prevent this infection. Of course, to totally prevent it, we can adopt more and more the minimally invasive cardiac surgery to avoid stenotomy. So, coming to these preventive guidelines, obtain nasal swab or PCR testing if available on all cardiac surgical patients. Class 1 recommendation, level of evidence A. Intranasal mupirocin within 24 hours of surgery and continue for 5 days in the absence of negative PCR testing or negative nasal swab for Staphylococcus. Class 1 recommendation, level of evidence B. Perform a chlorhexidine bath or shower in the evening before surgery. Class 2B recommendation, level of evidence B. Administer a cephalosporin antibiotic intravenously within 60 minutes of surgery. Continue for procedure of more than 4 hours and for not more than 48 hours. The dosing schedule should be weight-based. It is also class 1 recommendation, level of evidence A. Then restrict vancomycin to patients with history of type 1 allergic reaction to beta-lactams. Vancomycin should be administered intravenously between 60 and 120 minutes before the incision, and most for only one additional dose. This is class 1 recommendation, level of evidence A. An aminoglycoside should be added for one preoperative and at least one additional dose for gram-negative coverage. This is class 2A recommendation, level of evidence C. Patients with preoperative hypoalbuminemia should have their surgery postponed to receive enteral nutrition for 7 to 10 days if the procedure can be safely delayed. All distant extrathoracic infections should be treated before cardiac surgical procedures. So we do all types of culture preoperatively in cardiac surgical patients. Smoking cessation, continuous insulin infusion in diabetic patients as per different protocols. Blood glucose levels should be controlled and preferably below 110. topical antibiotic should be applied to the cut edges of the sternum, but it is controversial, and previously it was class 1 recommendation, level of evidence B. Bone wax either should be minimally used during during cardiac surgery for sternum. Closing the sternum using a figure of 8 technique may be preferable to prevent sternal dehiscence and infection. Closing a sternum with multiple fractures using the Robisac view technique may prevent sternal dehiscence and wound infection. So, treatment of deep sternal wound infection. Despite close adherence to these guidelines, wound infections may still occur. The treatment of sternal wound infection must be individualized based on the depth of the infection, the organisms that are cultured, and the patient's clinical status. Principles that will help to achieve the lowest morbidity and mortality in treatment of sternal wound infection are described here. That is the principles of management: appropriate assessment of the underlying causes, identification of causative or pathogens, surgical revision, thorough debridement, wound preparation and reconstruction with or without soft tissue flaps. So, conventional management has been post-anatomy medial stance was initially approached by surgical revision and frequent dressing, but it is not much effective. The method was flawed by long hospital stays, secondary superinfection with fungi, hemorrhage, and mortality was as high as 45%. An important contribution to the treatment of deep sternal wound came in 1963 from Shoemaker and Mandelbaum, who first described the technique of debridement, sternal reclosure, mediastinal antibiotic irrigation. Its use has been reduced by dilute antibiotic irrigation nowadays. Molina and co-workers, they described debridement, lateral reinforcement of the sternum, placement of combination of irrigation catheters and suction tubes, both anterior and posterior to the closed sternum. The skin is closed, the irrigating catheter kept in place for 1 week, and then suction tubes progressively are taken out over 5 to 7 additional days. Who have used a single approach for 4 years. He described 98% cure rate and no mortality in 114 patients. But there are limitations in patients' mobility and slower rehabilitation. High rates of failure are still being reported with this technique. Nonetheless, this approach is still used and is a viable option. Multiple procedures, eventually including the use of muscle flaps, were necessary in more than a third of these patients. So, 90-day mortality rate for patients with deep sternal wound infection remained high at 14.5% in with this technique. So, another technique used was healing wound infection without continuous irrigation is closed drainage with Redon catheter as shown in this diagram. The other techniques are soft tissue and muscle flaps, omental flaps. So, donor site complication resulting from omentum flap transposition remains high and include abdominal wall herniation, hematoma, and seroma. Another flaps are pectoralis major muscle flaps, but with it the mortality has again been high. Rectus abdominis muscular flap are more efficient in preventing dehiscence of the inferior third of the sternum, but it may not be taken on the left side due to Lima harvest. Now this therapy is coming and being used in all types of infection in the body, and this negative pressure wound therapy, this VAC therapy for sternum appears to be quite promising. Application of local negative pressure through an open pore polyurethane foam covered with an adhesive drape and connected to a vacuum source. Continuous drainage in a otherwise moist environment increases the blood flow in the wound and favors cellular organization and granulation tissue formation. This technique can be used as a single line treatment modality followed by reclosure as a temporary means of providing optimal condition for second line procedures such as flap transposition or plate fixation. Bleeding remains the most frequent complication associated with the use of VAC therapy, but this can be avoided by covering the right ventricle with paraffin gauze and performing debridement in the safe environment of a proper operating room. So these are the results of negative pressure wound therapy, adjusted survival for patients treated with multimodality therapy, including rewiring with or without pectoralis major muscle, advancement with or without plate fixation, either with WAC or without WAC. So it has been better treatment option. So these are another paper favoring vacuum therapy and guided by C-reactive protein levels. So in this paper also, this has also shown promising results with WAC therapy, and this is the algorithm which has been defined according to CDC classification. Remove all sternal-wide tissue cultures, sternal sparing debridement, rinse gently with saline, apply WAC therapy, 125 millimeter of mercury, continuous suction, vancomycin plus imipenem, and soft chest harness after 2 to 4 weeks. If CRP level goes below 70, then we can remove WAC, and if still more, then it can be applied for more times. So in this paper again, negative pressure wound therapy is safe and reliable option in mediastinitis. Again, another paper favoring negative pressure wound therapy. So recommendation for management of sternal infection. Use of dilute povidone iodine irrigation for the treatment of these sternal wound infection in mediastinitis should be avoided. It has not proved effective. Negative pressure wound therapy should be initiated whenever possible in patient when delayed sternal closure is anticipated following deep sternal wound infection. That is class 2 recommendation. A dressing barrier between the sponge and heart and gate vessel necessary when using negative pressure wound therapy to prevent tissue erosion, which may lead to fatal hemorrhage. Another important issue is that in deep sternal wound infection, there is sternal instability along with this infection. So chest fixation is also important part, and how to do it. When the bone is very
Sir, kindly wind up.
Yeah. New approaches of sternal reconstruction is in the base of, basically I want to describe these titanium plates, and we can fix the sternum with these titanium plates. And concluding my talk, deep sternal wound infection remains an important problem after median stenotomy, associated with significant morbidity and mortality rates. Good clinical practice based on appropriate preventive measures, early recognition and treatment are mandatory because they have been shown to provide significant improvement in outcome. Negative pressure wound therapy and rigid chest fixation are quite promising modalities to reduce morbidity and mortality significantly. Thank you.
Thank you, sir, for your wonderful presentations. I think question and answer can be taken up during tea time at the individual.
Actually, this sternal dehiscence is something as a coronary cardiac surgeon we see so often. But myself practicing only general thoracic surgery, we do mid-sternotomy very rarely, and that too for mediasternal tumors, etc. And we had one case in which we had a bad dehiscence. And actually this therapy, suction therapy, this worked very well. I think it has changed the results entirely. Earlier we used to keep on doing dressings for 6 months, etc. And this has changed the scenario very well. And those people who are here in thoracic may not appreciate the significance of sternal dehiscence, how much of a big morbidity it is there. Yeah, thank you.
Thank you.
Last, I would like to also
Comment something. Since morning I have been listening very eminent thoracic surgeons, and I learnt a lot the newer aspects in this. But being a chest physician, I feel that this thoracic surgery needs to be expanded to a peripheral level, and it is possible when it becomes a simplified and you can say can be carried out at a medical college level or even district level. Yes, we as a chest physician, we do feel a lot the need of the thoracic surgery in our many of the patients. What Dr. Diwar was saying, the early intervention. Yes, many of the patients we don't get this type of facility at the peripheral level. We don't have the trained thoracic surgeon. We should start something, fellowship program or some training program, whatever, at the medical colleges, so that these can be carried out at the earlier stage. Thank you very much. One thing I was saying, the congenital anomalies or thoracic wall deformities are not being covered. I hope in the next that will also be covered in this. Okay. I may have this.
Thank you, sir. One last just comment. We have already seen your excellent results over the last 20 years, sir, Dr. Diwan and the entire surgical team, and probably a good selection of the patient and post-op care, that is also equally important, early mobilization and supplemented with good antibiotic coverage. Everything is important. So we probably were lucky to have the team here, and thank you so much. We can have the question in the next T session. Yeah, thank you.
We'll be starting quiz dot at 5:30, so please assemble back in 10 minutes. We are sorry for the delay.